I am Francesca Torriani, and I am an infectious diseases physician, faculty physician at UC San Diego Health. And I'm also the program director of infection prevention and clinical epidemiology at UC San Diego Health. And I'm quite excited to present our new publication, a letter in the New England. Our workforce is composed by about 19,000 individuals. 11,000 are really full-on clinical, working in hospitals and clinics, and those are from nurses to physicians to technicians, EVS workers, and workers in the restaurants and in the food. And then by about 8,000 health sciences, who are some researchers, but some like me who are faculty and who have heavy clinical load, or pharmacy faculty who also have clinical duties, as well as the teaching services, residencies, and fellowships. We, as you may recall, offered vaccine. We started with the Pfizer vaccine as soon as it became available on December 16th, and we followed a prioritization in vaccinations that basically started with the immediately frontline healthcare workers, such as healthcare workers working in the emergency departments, and then going to the ICUs, and then going to the floors. And so little by little, quite fast actually, we were able to vaccinate 76% of our workforce by March 2021, and by June we had reached 87% of our force that was fully vaccinated. We almost exclusively gave mRNA vaccines. Pfizer, we gave about 1,700 doses more than Moderna, and that was due to the distribution of the vaccine. We had very high adherence with the recommended intervals between the first and the second vaccine, which I think is an important point of discussion. So it was 21 days or 3 weeks with Pfizer, and 28 days, 4 weeks with Pfizer. Next slide. So everything went well, and we already discussed this slide. As I said, we started vaccinating mid-December, and our numbers went down pretty fast, along with the curve, the San Diego curve of cases. And then we really had a minority of fully vaccinated individuals who had breakthrough infections, less than a third, and very, very mild. And so we felt in June that we were on top of everything, and economy kind of opened up, masking mandates went away, and then in July, right after July 4th, we started seeing an increase in our healthcare workers. Now remember that we test healthcare workers if they have minimal symptoms. So they get a red thumb and a test if they report on the daily screen one or more symptoms. And also we test all exposed healthcare workers at days when we find out about the exposure, and then at day 5. And so what we saw, and remember here, 87% of our healthcare worker force is vaccinated. We saw an increase in our breakthrough cases, and then we had also cases who were among the non-vaccinated or not fully vaccinated in red and yellow, respectively. Next slide. And when we looked at sequencing, we saw that this was primarily Delta. So by July, 99%, by the end of July, 95% of our cases of COVID cases were due to the Delta variant. And then by the end of August, 99% of our isolates are Delta variant. So the question that we came up with was, well, is this all due to the Delta variant? So are we having this surge in Southern California because now we've taken away masking mandates and there's much more virus circulating in the community, and this virus, because it's the Delta variant, has much higher viral loads and so is much more easily causing an infection. And so I want to discuss this next. So if you look at our total population, we're about 19,000 healthcare workers. By July, 16,492 were fully vaccinated. The breakdown between Moderna and Pfizer is here. And as you can see, we had 1,895 who were unvaccinated among our 19,000. And so 86% of the workforce was fully vaccinated, so quite a bit. And then when we look at, the proportion, clearly if the majority of our healthcare workers are vaccinated, we would expect with the rise, we would expect that there would be more cases among the vaccinated than the unvaccinated. But when we look at the attack rates, we can see that the attack rate stayed very, very low until basically at 2.3 until June. And then in July, the attack rate was 5.7 per 1,000 fully vaccinated healthcare workers versus much, much higher rate in unvaccinated at 16.4 per 1,000 unvaccinated healthcare workers. And so clearly this vaccine is still very protective, as other studies have shown, but clearly the rate increased in both, and so that was a concern to us. And when we calculated the vaccine effectiveness, we found that the vaccine effectiveness had gone from 94.3 in June to 65.5 in July. And this was once again for very mild symptoms and infections. So a case was defined as one or more symptoms and a positive PCR. So this is the vaccine effectiveness in a pictorial view, and as you can see, Moderna is in red and Pfizer is in blue. As you can see, very high levels until June, and then in July, as we discussed, it decreased. Moderna slightly higher than Pfizer, and then in August it further decreased. Moderna also keeping the effectiveness at 65%, and Pfizer going down to 49%. However, please notice the larger error bars, and so this 49% could actually be a little bit different and a little bit higher. So, as I said, we thought, well, could this be virus, basically the Delta virus, and this is just Delta virus, and that is why we have this decrease in vaccine effectiveness, or is there something else going on? And so to answer that question, we basically looked at the vaccine effectiveness by month or period that they had been fully vaccinated. So to show you here for both mRNA vaccines, because I think that the error bars are much different. If patients, and this is data for those who were diagnosed in August, if healthcare workers had completed their vaccine in January, February, the vaccine effectiveness was 51%. If they had completed the vaccination, the two vaccines in March and May, their vaccine effectiveness was much higher at 67%. And so we think that there is a combination of things here. There is much more disease in the community that is circulating, so many more opportunities for these healthcare workers to get disease in the community, as they reported to us, and also suggestion of waning of immunity, at right about 6 to 8 months. So key points for discussion, and I will stop here. There was this rapid increase of cases, predominantly in our very highly vaccinated and young population. The median age of our healthcare workers was 39. They are very healthy. Vaccine effectiveness fell precipitously in July and in August, concomitant with the rise in the Delta variant and with the ending of masking mandates. And when we analyze the data, the cases in July and August, vaccine effectiveness was significantly lower in those who were vaccinated January and February versus March to May, which suggests waning of the immune response. So, having said this, does it mean that these vaccines are not working anymore? No. They are working very well. So this is really about saying what can we do to better? But we have a ways to go. For instance, in San Diego County, we can see that unvaccinated individuals are 4 times higher, have a 4 times higher case rate if they're not fully vaccinated than vaccinated, 68 per 100,000 versus 15.2 per 100,000 vaccinated. And also, more importantly, is that hospitalization rates were 86 times higher in not fully vaccinated, and 1.71 per 100,000 versus 0.02 per 100,000 fully vaccinated. So these vaccines work very well. They work as they are supposed to work. We had really even more an effect in really preventing infection overall. And that is why we're advocating that for certain populations, we may need boosters. There is booster data available, and the ACIP committee, which is an advisory committee of the CDC, is actually looking at the rationale for boosters and looking at the data for boosters, and is going to be meeting on September 17th to make decisions. It might be that they decide that they should narrow the boosters for a population that is either more at risk of disease or of giving infections to others, like the long-term healthcare facilities and other acute care facilities, and maybe to patients who are more susceptible for, severe disease, which could mean patients who are 65 or older, or who have other comorbidities. Delta variant is definitely associated with higher viral loads, and so we believe also transmissibility. And we found in our cohort that breakthrough cases were, on the whole, much more symptomatic. They had very mild disease, but they still had symptoms, even in those who were fully vaccinated. We know now studies both with Pfizer and Moderna that have been submitted to the FDA show that a third dose of an mRNA vaccine boosted neutralizing antibody titers up to the same levels that had been achieved 2 weeks after the second vaccine. And so we're waiting basically for that data to be looked at by ACIP and by the SAGE WHO committee, and for recommendations to be given in the next few weeks. Meanwhile, and I will end with this one, is that our work is still there, right? We still have, in many regions of the US, we have high-level transmission of this virus. And so, the counties that have restarted masking mandates indoors and in crowded venues for everybody, including vaccinated individuals, have seen a decrease in their community transmission. While counties like ours, that does not have this mandate in place, continues seeing very high levels of disease. There's clearly a lot of questions about masking standards, including which is the best mask and the best wear. And I think that it really depends on what we want to achieve. If we want to achieve source control, so prevent aerosolization, a mask, a good fitting mask with double layers is probably sufficient. But clearly, if we want a better filtration, maybe the KN95s are better. There's definitely the need to further improve ventilation indoors, particularly in schools, and then to continue testing and have very strict testing protocols so that you can identify people who are positive and take them out from the infection. And then we want to protect from new infections, continue to increase vaccination coverage. In San Diego, I will tell you that our vaccination rate is touted as being around 71%, but actually that takes into account only the population that is eligible for vaccination and excludes children who are also susceptible. And therefore, when we look at that, we go down at probably more like 55-60% of the population is vaccinated. And then wait for, as I said, ACIP and SAGE to tell us more about which areas will benefit from boosters. And I thank you for your attention.